Welcome to Ask Dr. Mingle, the Q&A series from Mingle Health answering your questions about quality programs and the transition to value-based care. I'm Kyle Breckel. I'm a digital marketing specialist here at Mingle Health, and I'll be hosting this episode along with Dr. Dan Mingle, founder and CEO of Mingle Health. Good morning, Dr. Mingle.
Good morning, Kyle, and good day to all of you tuning in. It's great to see you again. I'm Dr. Dan Mingle, and I'm here to answer your questions to the best of my ability.
Our first question for you today, Dr. Mingle, comes from Georgina. And Georgina asks, we are a Medicare Shared Savings Program, MSSP, Accountable Care Organization, ACO, transitioning from the web interface to the APM Performance Pathway, that is the APP. So what do I need to think about to manage our participants to support APP reporting?
Great question, Georgina. The big difference between web interface and APP reporting is the number of data points you need. Web interface requires 248 patients for each measure. It's most easily achieved by distributing the pertinent subset of the required 248 patients to the practices that hold data on those patients and manually abstracting the charts to answer the important performance met question. But the all patients, all payer requirement of eCQMs and MIPS CQMs of the APP makes manual chart abstractions prohibitively expensive. Even the proposed Medicare CQMs is an enormous lift to perform with manual abstractions. No matter what method and what vendor you choose with which to meet the APP quality reporting requirements, there's a basic set of requirements you're going to need to fill and to help your participating practices fill. First, you need to know your participating practices. You know, the TIN of each practice, the location of each practice, and how many locations per TIN, the participating providers, key contacts, the inventory of health IT systems in use, practice management system, the electronic health record, the system vendor of each of those applications with key contacts, the hosting vendor of each of those systems with key contacts, and the data access contacts, not just organizational or business contacts. There can be multiple options to get data from each practice and each system. You'll need to identify the strengths and barriers existing for each practice and each of their vendors. You'll need to choose a workable method for each system for each practice and then implement it. Options include: you may utilize a database technician from the systems to extract the needed data from the health IT systems, from the databases. The person who writes the extraction can be from the practice, the product vendor, the hosting vendor, or even a third party. If it's a third party, that third party needs to get access to the data through the hosting vendor. A practice member can trigger canned reports that include the needed data. You have to identify if that canned report is written, if it's available, if it's accurate. You can use automated exchange of data per interoperability capabilities and requirements that certification is increasingly requiring. And you can use manual chart abstraction in some special cases. Now, there needs to be someone assigned to do that work. That person can be the ACO, or the work can be contracted from the quality vendor or registry you've engaged, the integration vendor you've engaged to electronically integrate your data, or another third-party vendor with the needed skills and experience. Common barriers to this basic organizational step includes: first, it takes a substantial amount of time, knowledge, and experience to do it efficiently and effectively. In my experience, ACOs never have excess staff on hand with the time enough nor the knowledge and experience to do it. It's not that the knowledge and experience are inaccessible to them. It's just very time-consuming to get there in the face of their already substantial responsibilities. Participating practices, more often than not, have reluctance to share data with their ACO. They may be willing participants and partners in the ACO, but competing with other ACO participants in many other aspects of their local care. So even though they're partners, they're a little reluctant to share their data with organizations that are also competing in other areas. Having a neutral third party mediating these details is often necessary to achieve the cooperation needed. Once it's set up and running, there's also routine maintenance required. Errors in the data are inevitable. They need to be recognized, understood, and addressed. Practices will upgrade their systems. This often changes the data flow, creating new errors that need to be recognized, understood, and addressed. Practices will change systems, that is, migrate from one application to a different one, or they'll change hosting vendors, often requiring a new assessment of the best ways to get data and a new set of errors that need to be recognized, understood, and addressed. There are also going to be new practices and providers joining the ACO, each requiring a new assessment of their HIT infrastructure and decisions made for optimum data exchange. So no matter how you cut it, it's a lot of work to be done, and most ACOs are going to need help, not just a technical solution to provide their reporting.
And our next question for you today, Dr. Mingle, comes from Charlene. Charlene asks, I understand I'm going to have to work harder to earn a MIPS positive adjustment as the program picks up again and matures post-COVID. Do you have any advice for us?
Charlene, you're absolutely right. MIPS is getting harder. Earning the full 30 points in quality is becoming more important to achieve adjustments in the positive range. It's certainly achievable, but it is hard. Now, the score you need for each measure is published in advance. It's based on national scores from 2 years prior to the current performance year. So the required performance to get to a specific score is knowable, but it's not necessarily easy. It will take a coordinated effort of your whole practice to achieve optimum results. You need to plan the care of your patients. Planning care is important around all aspects of care and is particularly important around your target measures. You need to know who in your practice will be asking the questions, taking the measurements, and or exploring the record to determine that the care is needed. You need to record those indicators in a standard place in the electronic chart that is electronically recoverable in order to measure your performance. You need to know who in the practice will be providing the care and how they will learn that it's required. The person who provides the care should optimally be working from a protocol. Now, protocols must be correctable. Practice response to deviations from the protocol should begin with an examination to see if that protocol needs to change to address the exceptions that were highlighted by this deviation from protocol. You need to record the care provided in a standard place in the electronic chart using structured data that is electronically recoverable to measure performance. And you need to measure regularly, rethink and rewrite your protocols, reassign and retrain your people, and build or correct EHR documentation templates as indicated. Now, as you struggle with periodic adjustments to your quality reporting infrastructure, always look for choices to keep your quality reporting scalable, flexible, and affordable. As for scalable, you'll need to add measures, either more measures for the same program or new additional programs that require different measures. As for flexibility, you'll need to change measures as old measures top out, as new medical evidence renders current measures obsolete, or new health priorities require new focus to your measures. As for affordability, you need a single infrastructure that can be configured for any conceivable measure. You should never jury rig a measurement infrastructure for a specific measure. Now, jury rigging may be necessary for a rapid response to a new measurement, but you should bring it into a common single protocol or infrastructure as quickly as you can. You should have standard places in your data system where you can find all the structured data needed to that you can identify using an electronic query. Now, one of those areas needs to be all the expected permutations of denominator specifications, things like age, sex, risk factors, chronic diseases, recurring conditions, medications, allergies, lab results, and vital signs. all expected permutations of exclusion criteria, all expected permutations of numerator criteria. Now, there's all kinds of overlap between those, so it's not completely three different systems, but think in terms of structured data for each class of data, and not special areas to record the results for just a single measure. Clinical and documentation workflows should make sense even beyond the context of quality reporting. Your routine workflows should serve both as efficient and effective documentation for quality reporting as it is a reliable data for patient care. More on that later, I think, but a great question. Great question, Charlene.
Thank you, Charlene, and thank you as well to Georgina for the excellent questions today. And thank you, Dr. Mingle, for sharing your insight with us today.
Thank you, Kyle. And thank all of you for your great questions. I want to be helpful. I want this to be useful to you. Don't hesitate to correct or supplement my answers. Share your experience. Ask your questions. We can be smarter together.